What has happened more recently, and that is since 2008, when one of our biolitazine dione medications, which was rosiglitazone or Avandia, was believed to actually increase the risk of heart attack in patients with diabetes. And again, patients with diabetes already have a tremendous increased risk of having a heart event over the general population. We're looking at 4 to 6-fold over the general population. So having a diabetes medication that could actually increase that risk is definitely a no-go. So the FDA mandated at that point, 2008, that every drug that comes to market for the indication of treating diabetes for type 2 patients has to show cardiovascular safety. These studies are done on top of standard of care. What means is that when these patients are enrolled in these cardiovascular outcomes trials, their blood pressure and their cholesterol, as well as their glycemic control, is being adjusted simultaneously to meet whatever targets have been determined during the time that the study was taking place. So it's not that they're just put on these drugs and let's see what happens. They're put on these drugs in addition to their blood pressure, their statin medication, aspirin, beta blocker if they had an MI. All of those things are already in place. So on top of that is really what we're looking for. And so in 2018, the ADA came out specifically in their guidelines stating that once you have a patient that's on monotherapy, which is typically after or in addition to therapeutic lifestyle, we start with metformin. Weight neutral, doesn't cause hypoglycemia, has been around for a really long time, and has had shown some cardiac benefit with the UK PDS follow-up data. What do we do after metformin? And as I told you, we have 11 classes of drugs to choose from. How do you know what to go to? And so the question that needs to be asked is, does your patient with type 2 diabetes have underlying cardiovascular disease? And if they have underlying cardiovascular disease, that is where we then turn our attention to these cardiovascular outcomes trials. So we have many drugs that have shown that they're at least safe for use in our patients with diabetes. But we also have shown some agents, not necessarily complete classes, but some agents within class that have also demonstrated not just safety, but actual benefit to patients with underlying cardiovascular disease. For instance, in the GLP-1 receptor agonist class, we have one drug, liraglutide, that has actually shown a reduction in that MACE outcome compared to standard of care. We also have in the SGLT2 inhibitor class 2 drugs currently that have shown reduction of MACE outcomes, and that would be your empagliflozin or your canagliflozin medications. So we have 3 drugs right now, one in the GLP-1 receptor agonist class and 2 in the SGLT2 inhibitor class that have shown cardiovascular disease protection in patients with established cardiovascular disease. So that is now where we as clinicians need to start deciding, when we're choosing medications and intensifying treatment, what is going to benefit our patient. I tell my patients it's not just about your sugar. Diabetes to me is heart disease, and so when I'm looking at treating the diabetes, I have to take into consideration this underlying heart disease that they likely have.